and welcome to DC to B Revolution, where we're thinking big to live large. I'm Noah Volz, and today I have a really great guest I'm really excited about. Her name is Dr. Jensen, and she has a varied history in the chiropractic world. She got her PhD from Oxford, and she's a published author. She's published a lot of different research articles, and she's considered an expert in emotional wellness. And she's the developer of HeartSpeak, a powerful, innovative stress reduction process. And so, Dr. Jensen, thanks for being here.
Yeah, welcome. Well, thank you. I'm really glad to be here. Thanks, Noah.
Yeah, definitely. And so I know that there are a lot of students who are curious about research and want to be really involved in doing research in chiropractic or in health or in wellness. So I wonder if you could talk a little bit of your origin story, how you transitioned from a clinician into a researcher, and what that looks like for you now.
Yeah, sure. Yeah, I was practicing in North Queensland in Australia for 11 years. And during the last few years of practice, I was doing research in practice. I was doing some kind of fringy things, and I thought, well, and I was seeing amazing changes. Let's back up. So when I was in practice, I was noticing in my patients that I was adjusting the same segments of the spine, and I was also, they were coming in with the same complaints. And, I know I was giving good adjustments because people were leaving better, feeling better. But then, 3 months later, a month later, 6 months later, whatever, they'd come back in with the same complaints. And not that I was symptom oriented at all. I wasn't. Even in the maintenance patients that I saw, that every 3 whatever months they'd come in with the same complaints. We never really seemed to get ahead. We just seemed to be keeping things at bay. So then I went back to my original chiropractic philosophy from D. Palmer. What are subluxations caused by? Yeah, because I was really curious as to why I had to adjust the same areas of the spine each time. Subluxations are caused by trauma, physical stress, toxins, chemical stress, or thoughts, mental, emotional stress. And, we chiropractors were quite good at addressing physical stress. And a lot of us are good at chemical stress, helping people detox and have the right nutrition. But we didn't have very many tools to address mental, emotional stress, to help patients with mental, emotional stress. And sure, an adjustment will help people feel better mentally, emotionally, but not, why did it keep coming back? So I started looking around, I took a bunch of courses, and I was seeing amazing results in my practice when I started to add this component. So that's when I started to say, hey, we got to do some research on this. What am I seeing in practice? Is it really what's actually happening? So then I started designing a few little studies, and I started to do some data collecting in practice, and I found out I was doing research really poorly, really badly. And as a result, it was really hard to publish what I had done. So I thought, right, if I'm going to be serious about this, and I was very serious about, helping chiropractic profession advance, I had to put my money where my mouth was, so to speak, and actually contribute to the evidence base. So then I started looking around who was doing good research, who was doing good clinical research. And really, it was Oxford in the UK. So I applied on a whim, and I actually got accepted first to do my master's. And so sold up in Australia, off I went to the UK, and did my master's and then my PhD. And I don't exactly know how I got accepted to either. Knowing what I know now, it must have been a fluke. And here we are later with 2 masters, a master's from Oxford, a postgrad certificate from Oxford, and a PhD from Oxford. So it's been an interesting journey for 10 years.
Yeah, that's so crazy. And so I'm when you were at Oxford, were you primarily doing chiropractic research? I mean, you said it was kind of a fluke that they let you in the first place. Oxford is not the first place that I think of when I think of evidence-based chiropractic research. So can you unpack that just a little bit for us?
Sure, yes. Yeah, so yeah, it was really interesting. Yeah, I was the only chiropractor around in the program, and the only alternative healthcare professional as well in my PhD program. In my master's, I was pretty much the only alternative person in there too. Most of them were psychologists and social workers of that nature. And I was not only doing something that was off the beaten track for clinical medicine, I was also doing something off the beaten track for chiropractic. I really wanted to study the effect, I wanted to do a big clinical trial on an emotional healing technique with depression, your average normal everyday depression. Not that depression is normal, but the feeling blue, not the clinical, major depression where people are suicidal. Not interested in that. I wanted to help the general population just lift it and feel better, which I had success in practice. So that's what I got accepted to do my PhD for. But then when I was demonstrating this kinesiology-based process in my department, by the way, my department at Oxford and my PhD was the Department of Primary Care, Health Sciences, which was hardcore medical researchers. I had some of the top names in medical research around me. And also in my department was seated the Center for Evidence-Based Medicine. So this is where it was happening. So when I was first doing my very first presentation in my department, and in your first year at Oxford, you're pretty much just figuring out what you want to do. So I was demonstrating, there was about 30 people in the room, 25, 30 people. Some of my students, cohort, and PhD students and some medical researchers. And I really didn't know who was who at the time. And I was demonstrating my muscle testing technique, and a statistician in the back of the room stood up and goes, "Look, could you just stop talking, please? Because if you don't stop talking, I'm going to leave." And my supervisor, bless her, she stood up and said, "Look, this has not been proven. This is not scientifically validated. She's doing exactly what she needs to do and in exactly the right place." And so he sat down, and it actually turns out that through 2 years later, that fellow in the back of the room became my secondary supervisor. Wow. So yeah, he was very impressed with the research methods and the data we were getting, and he came on board. Yeah. And what's really interesting, at my graduation, my supervisor, my primary supervisor, confided in me that, she was a GP and a medical researcher, hardcore medical researcher. Both of them were, by the way. She confided in me that, she really didn't think this was going to work. So she wanted to be there when it happened. So it was interesting. Yeah, it was heckled, harassed, ignored. Pretty much most of the time I was at Oxford. I was at Oxford for the better part of 10 years. And it was only in the last couple of years that people started to pay attention to what was happening. Yeah. So actually, as a result of that, the first presentation I did at my department, and a few other things that happened in that first year, I realized, I was actually told, no, you can't actually do a randomized trial on this process until you show us that muscle testing actually works. So then I started to validate muscle testing, and that took a life of its own. And in the end, I wound up putting the depression study on a back burner, and then just did a series of 6 diagnostic test accuracy studies on the validity of muscle response testing, the way I use it. So which wasn't kinesiology, applied kinesiology, by the way. Applied kinesiology is one thing, but the muscle testing research I did was not applied kinesiology. It was just muscle response testing.
Got it.
Anyway,
they're similar, but they're related. They're similar, but they're not the same thing.
Yeah. So there's a few basic differences. In AK, you are testing a variety of muscles, and the weakness will mean certain things like organ dysfunction or neurological dysfunction, which might mean organ dysfunction or whatever, meridian dysfunction. But with muscle response testing, which is used by about over 1 million people around the world. And why, by the way, also applied kinesiologists use muscle response testing, but they make fun of it. They call it the arm pushdown test. But one of my first studies I did was to determine how prevalent the arm pushdown test was used, and it was used by about over 1 million people around the world, we estimated, which is quite a lot. And yeah, so AK tests every muscle. Muscle response testing is basically the same indicator muscle over and over and over again, with changing what you're testing for. Does that make sense?
Yeah, completely. So it sounds like, the progression changed, and you validated muscle response testing. Is that what I'm hearing?
Yeah, actually, yeah, we got some very exciting results. My first study, the first study was a prevalence study, but then the first diagnostic test accuracy study, it was quite a big study with almost 100 people assessed, and we found that muscle testing can be used to accurately distinguish lies from truth.
Cool. And
yeah.
No, go ahead.
Yeah, so that was, I should really explain how my methods worked, shouldn't I?
Well, we can also put links to your papers in show notes, because that will explain exactly what you did, which was beautiful. Yeah.
Yeah, so they didn't believe me that I got such a big margin that they had me replicate it. So the replication study, and then 3 or 4 studies after that supported the findings of the original study. So now we have 6 studies to show how valid muscle testing is, which are now in the process of being published. So it just got exciting.
Wow, really exciting. And so what impact do you see all of these studies having on chiropractic? Or really, I mean, muscle response testing is not exclusive to chiropractic. So what do you see the response being to that validation, and how is that really going to change the different types of conditions or symptomology that muscle response testing is able to provide information towards?
Yeah, you're exactly right there, Noah. Muscle response testing is a tool. It's a test, and any test gives you information. That's exactly right. And how you apply that information is up to you, the practitioner. And then, there's different ways to apply it, whether it's through applied kinesiology, through touch for health, through total body modification, heart speak, contract reflex analysis, CRA. I mean, there's 100 different techniques that apply the muscle testing within it. And as far as how it can be used, so now, yes, we found that muscle response testing can be accurately used. Now, each of those technique systems is responsible to show that their whole technique system is effective. For instance, we've been working with the NLT people, the neural organizational technique people, and we're planning a study, hopefully, that will show that NLT is effective for traumatic brain injury. So while it's now going to be a randomized trial where we'll have a series of participants who have had traumatic brain injury, and then they'll be put through the specific NLT protocol for them to see if and compare them to a control group which won't receive the NLT process, and we'll compare the results to see if the NLT is effective. So then, okay, so the next step now is to show if these different technique systems are effective and how effective.
Awesome. And so you talked about the NLT study. Are you doing any studies specific to HeartSpeak and specific to kind of TBI seems like one of those things that's kind of in the chiropractic realm, but taking it outside of the chiropractic realm into, we say we're doctors of the nervous system, so it doesn't seem like behavioral modification or psychology or neural reprogramming or that stuff should be that far out of our scope of practice, but we're still considered very musculoskeletal. So do you have any plans in terms of HeartSpeak and in terms of moving our tool set into that arena?
Well, yeah, actually I just spoke with a member excuse me, a head of the IRB, an IRB committee today about the possibility of doing some research on HeartSpeak, and and also muscle testing. I want to do more muscle testing studies and more specifically surrogate testing, which is really common from under muscle testers, where you're using another person's muscle to test the someone who can't be tested, for instance. And I also like to do muscle testing, self-testing, which is also quite common out there. But as far as HeartSpeak goes, we are looking at reducing stress levels. It's hopefully going to be a pilot study, hopefully get it approved sometime soon. See if HeartSpeak can reduce overall stress levels, what the participants are actually experiencing in real time. So that's on the cards. I mean, I have lots of ideas, but only so much time to do it.
Yeah, and speaking of that, my audience is primarily students, and many of those students are probably really interested in the research that you're doing, interested in research in general. Some of the schools have more developed research departments than other schools. What would your recommendation be to students who hear this interview and are really excited about the work that you're doing? How could they support you, or how could they get involved?
Okay, great. Thank you for asking that. First of all, there's a couple of things. When I was in chiropractic school and for most of my pre-Oxford life, I was told, oh, do a case study on that. Oh, do a case series on that. And case studies, if you look at the pyramid of evidence as far as how good of evidence a case study is, it's right at the bottom. It's a qualitative study, which is really not considered good evidence. Case series are a bit better. So even though we are told to do case studies, I'm going to really urge you guys not to. Whoops, I don't know why it did that, but to not do case studies, to actually take the plunge. And if you're going to do a case study or a case series, do a small trial instead. It doesn't really take that much more effort. In data collecting it does, but in the writing up and the analysis it really doesn't. So I would suggest that, first of all. Also, I did spend 10 years at Oxford, and in that 10 years I was not asked, actually I was only asked one time, how does muscle testing work? Where a lot of practitioners would want to know, hey, how does muscle testing work? And no one really in my department really cared how muscle testing worked. They wanted to know if it worked, how well it worked, and does it cause harm? That's the job of a clinical researcher. We spend a lot of time and a lot of resources, a lot of chiropractic resources, figuring out how chiropractic works when they don't really care. The policymakers and the funders, they don't want to know how something works. They want to know if it works and how well it works. So why don't we shift our funding to clinical studies, to do trials, randomized trials, instead of, brain scans and things like that. We need to do more trials, and then once we get a series of trials, we can then do a systematic review, which is right at the top of the pyramid: systematic review and meta-analysis. So how can students get involved? Well, they can take the plunge like I did when I was in practice. Just jump in, and trial by fire. I learned so much, and there's nothing wrong with that. I also am free to help people. If people are really interested in doing and really committed to doing a study, I can certainly help people through that. You can contact me at Dr. Ann at drannjensen.com. Also, the program I did at Oxford is open now to everyone. There is actually another chiropractor in the program. The best thing to do is and it's one of those programs you can fly in for a week, be exposed to some of the best clinical researchers in the world, learn from them. First, do a master's in evidence-based healthcare, and you can you fly in for a week. Usually courses are 5 days or 4 days, and then so it's a series of I don't know how many courses, but they're module based, so they're really designed for clinicians in the field. So that you can find that if you search the Oxford website for Masters in Evidence-Based Healthcare, which then progresses on to a DPhil. They call a PhD a DPhil at Oxford, a DPhil in Evidence-Based Healthcare, and which was a really amazing experience. I just had an amazing time there. It wasn't easy, and you had to be committed. But not once in those 10 years did I ever question, am I doing the right thing? So go ahead and apply. Now I hear more that there's a program similar to the one I did opening up around. So get outside the chiropractic research fraternity. It's very stale, very tired, and very closed. I must say that I've been asked to speak at 7 conferences this year since my first papers are published. 7 conferences, and not one chiropractic conference was I asked to speak at. There were kinesiology. I'm speaking at a physical therapy conference, 2 energy psychology conferences, and kinesiology federation kinesiology conferences. So get outside the profession, shake it up a bit. We need good quality research, and it's the young ones like you guys that need to do it. The old ones, they're tired and retiring, and they're stuck in their ways. So it's up to you.
Yeah, that's the perfect call to action for this channel, because that's really the essence of it. That's why it's DC to be revolution. It's young people taking control of the profession, making it what we want to see it so that it can serve more people and, help the maximum number. So thank you for, closing with that and really, bringing it full circle. So this has been a production of DC to be Revolution, where we think big to live large. I'm Noah Volz. Dr. Ann Jensen, thank you so much for all of your advice and wisdom. And, this is to chiropractic research flourishing in the future.
You're here.